Go ahead. So with that, and so I covered everything up to the start. I mean, I did everything through the posterior pituitary. Those are important. The major hormones, and I mean, just a quick backtrack because I think this is really where it starts to get everything was sort of generalized. But to understand, you certainly are going to need to understand the roles of oxytocin, an antidiuretic hormone, and what they do. Okay, I think they're because we're going to revisit them more than one time, particularly the antidiuretic hormone, which you'll see a bit. And then the whole idea of this, what I call the arc, which is the fact that the hypothalamus, which is where the blood-brain barrier is weakest, is basically the where whether it's chemical signals, osmotic signals, pH is effectively a chemical signal, where different things are interpreted in the bloodstream, and then basically it becomes the mechanism to generate either upregulators or downregulators from the posterior pituitary, which effectively is part of the hypothalamus. It's just an extension. And then the neurotransmitters that come out, and you can see the proximity from these things that are there. And you can see, I mean, here's the extension of here's the hypothalamus, here's the infundibulum, the little extension. This shoot that has, obviously some additional tissue, but effectively what's coming out of there being secreted are, for lack of a better term, neurotransmitters, even though they're 9 short chain polypeptides, oxytocin, antidiuretic hormone. We make them genetically all the time. That's Pitocin. And something that I talked about, it's called DDAVP. Because AVP means vasopressin, DDA, as I'm sure you guys know, indicates genetic origin. You know, we know who to talk to about that. And voila, basically there's a lot, they what they call regulating and RHs. So you're going to see, when you look at the hormones, here they are. Particularly the GnRH, we're going to do a lot about that. That's gonadotropin regulating hormone. So you have basically the growth inhibiting hormone for growth, the prolactin inhibiting hormone. I mean, you can see these. So understand when it says RH, it's a releasing hormone. So it's an upregulator, inhibiting is a downregulator. They're not one for each one of these, but I think if you look through it, you'll get all the information that's there. I talked about diabetes insipidus, known as salt diabetes, which is important because diabetes has nothing to do with sugar. It just means the great thirst. In both of these instances, there's an excessive amount of diuresis. You're losing water and you're thirsty. So, which brings us to the 6 major hormones. Growth hormone, thyroid, stimulating hormone, growth hormone, all over the place. Most cells have receptors. Thyroid stimulating hormone is tropic or increases activity of the thyroid. The adrenal cortex, ACTH, or adrenocorticotropic hormone, directly receptors on the adrenal cortex. Follicle stimulating, follicles, gonads, ovaries, and testes. They're the ones that are going to effectively stimulate those follicles to make eggs and sperm effectively, and respectively rather. And luteinizing hormone, again, tropic on those same areas, but on the cells that release either estrogen, progesterone, or testosterone. And prolactin, maybe the role is, we know it plays a role in lactation, certainly plays a role vis-a-vis pregnancy. The interesting thing about it is it's in the parlance what we call a tell. Okay, tell. You don't know what a tell is. Did you ever play poker? You ever watch in baseball? There's been a big thing looking at signs. People telegraph. It's called telegraphing pitches. In the old days, if somebody would do this or do this before they were going to throw a curveball or a fastball, and that's how they tried. That was called. So in the parlance, it's called a tell. Poker players, you in the poker circuit, they look for, do they do this? Do they open their cards, fold their cards? Are they bluffing, etc.? So I'm glad you don't know any of this, because that means you weren't like me and spent an inordinately large amount of time at the casino. Probability studies, those green tables with the cards, I like those. You were there. I'm looking for you next time. I won't tell. moving on. So it's called a tell. The tell of pituitary hormone of a pituitary tumor, interestingly, is inappropriate lactation. And it can be a man or a woman. Obviously, a man would be very inappropriate, but a woman starting to lactate, not being pregnant or not having recently delivered, all of a sudden the back clinicians go, whoa, we better look at the pituitary, see what's going on. So that's, and you'll see that they'll say this here. We learn that anyway. Everybody learns it. So, somato means body, tropin is growth, growth hormone produced by the same name cells. The key issue, it is glucose sparing, okay? And because of that, it effectively offsets insulin. Growth hormone is the perfect, you've heard me say this before, I'm sure, the perfect performance enhancing drug because it increases metabolism, initiates repair via replacement of tissue at the expense of fat for energy. So effectively, you're producing lean muscle mass. So it's so extraordinarily important. Years ago, when a child was on the graphs, with like my great grandson, you're measuring the length, you're measuring the weight, you're graphing it out in a particular graph and see what percentile they fall into. If they were in the old days, if they were in the 25th percentile at a certain age, and you start to get information about that early on, that was the criteria to use growth hormone. We didn't make it like we do now. Genetically, you had a very limited amount, and you had to meet a lot of criteria. And one of our friends, and that child now would be in the 40ish. Friendships sometimes come and go, and distance makes them disappear. Nevertheless, I don't know what the follow, but he was getting these, and very interesting. So growth hormone, now that it's made genetically, has become very much an in vogue treatment. When used appropriately, fine. When used inappropriately for performance enhancement, by utilizing fats as an energy source, now you run into the problem with metabolizing fats, lots of energy, good thing, bad thing, fatty byproducts circulating around, inevitably cause keto acids, keto bodies, deterioration of blood vessels, a lot of problems, as do anabolic steroids. So again, you're going to see growth hormone and insulin are in a unique tug of war because insulin does very much similar things, but utilizes glucose as the energy source. Our bodies are geared, and I'm sure you know this. Basically, the pecking order is, the food groups: carbs, fats, proteins. We use carbs first, the basis of the ketogenic diet, South Beach, Atkins diet. It's your carbohydrate sparing. We use carbs first. Carbs are not available, then we use fats. Fats, problem with fats, if the fats in your diet are not healthy fats, okay, or if you're not doing it by intent, you have a lot of problems associated with it. When someone is starving and they've gone through those, then they start to break down proteins, and that's a very significant problem. You want to avoid that. So this triggers the liver to break down glycogen into glucose, increases blood levels of fatty acids for use as fuel, and encourages cellular protein synthesis. Indirectly, liver, skeletal muscle, and bone, and then we call them insulin-like growth factors. Insulin-like just means they behave metabolically like insulin, but we're using a different energy source. That would be the major distinction. You're going to hear, as we move on, a lot about growth factors. Those are some of the ones we're starting to understand in modern physiology. We didn't know about a lot of these things until the 80s and 90s. A lot of these things were not clear. Wound healing was in its infancy. Understanding the growth factors, it's like when someone gets, and we'll talk about that vis-a-vis sport, a platelet-enriched plasma injection. Okay, very, very commonly used. Those have platelet-derived growth factors. It's the key issue. It's not magic. We have these locally acting chemicals that we call paracrines because they work locally that selectively increase growth. It's a good thing as long as everything is used properly. It's all about that. I think it's really fascinating stuff. I mean, I read about this stuff all the time. I know you're all busy. And getting back to exams and things like that, I had this discussion today with Doctor, and that's why I try to be understanding. I didn't. A lot of you have to work multiple jobs. You do stuff. Your commitment to athletics and sport, as many of you have, is very, very time consuming. I mean, I was very lucky. I didn't have to do that stuff. My sister, my sister was already married by the time I started college. I was it, and at that point, my dad's business began to become very, very lucrative. I had one job in life to study. Once I got into the habit of doing that properly, 2.5 years of college, because I was a F up, then everything is like that. I didn't have to worry about where the bills were coming. I didn't have to work. Hey, Dad, I need some more money. Sure. What'd you get in the last test? Hey, good. I'm sending it. Snail mail. 55 freaking years ago. Give me a break. So I had that discussion with Dr. Hillick. So I'm trying to be forgiving. But this is a warning. You're new to here. You're the only new one who's here today. God bless you. I knew I liked you for a reason. But the guy you said, you gotta think of what you're saying. Joking, fooling around. Okay. So understand what it is. Growth hormone stimulates. So IGFs, cellular uptake of nutrients, DNA and proteins, formation of collagen, da 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 da. Growth hormone, most cells to enlarge and divide bone and skeletal muscle. Athlete 101. You see that Sidney Crosby's on IR for 4 weeks? And 4 weeks, see it right when we need him. So, regulation, growth hormone release or inhibition. So you have a GHRH and GHIH, okay? You can see the triggers are there. They're fairly obvious. Triggered by low blood hormone levels or glucose or high amino acid levels. So, I mean, if you eat, at least the whole idea of consuming protein powders, breaking them down to amino acids, then all of a sudden that, if used properly, that should trigger growth hormone. And along with appropriate exercise. And again, I caution anybody who's doing this, because we were looking at them yesterday. My wife and I were at Sam's Club. And I mean, these big giant things, the muscle milks and all those different proteins. They're really good today. You've got to be very careful to make sure you hydrate properly. And here's the inhibiting one triggered by growth hormone or high IGF levels. Okay. And again, interestingly enough, ghrelin, which is, I don't really ask a lot about, hunger hormone also stimulates growth. And you can look through all those things that are there fairly straight. Most of it is fairly straightforward. The actions are fairly straightforward. The graphs are useful. This is also the chapter when we get to too much and not enough syndromes. Too much is important. Okay, so hypersecretion, if the growth plates are open, it results in either gigant or giantism, whatever you want to call it. Okay, I was always taught giantism, but if they want to stick a G in there, I'm fine. And in adults, because the growth plates are closed, bones thicken, and typically it's very distinctive and quite disconcerting by people who have, you see the acral areas, fingers, toes, hands, feet, jaws, facially becomes very enlarged and almost scarily distorted when you look at acromegaly. That's more of an oddball than anything else like that. And then hyposecretion is the kind they call this. There's lots of different kinds of dwarfism. There's pituitary dwarfism. This is the example of that. We have genetically ones, achondroplastic. You probably just learned about that in genetics. You didn't learn about. Did you learn about different kinds of dwarfism in genetics? Yeah. So I mean, it's a topic you would consult there. See, I was going to say something silly like Munchkin disease. We aren't even supposed to term dwarf anymore. Little people, right? Not midgets. I correct me. I'm seeking political correctness. I actually got a smile out of Jenna. It's nice to see you're listening. It's an old routine, I think. When I got the stand up gig, you're coming front row. I'm paying. Yeah, you always need somebody who's like a page. They call them a shill. Somebody in the audience. It's like the magician has somebody. I'll volunteer. Good. Do I know you? No. I saw you in half. So again, this is some of the things. That's one of the things that can be treated. In adults, it's not typically a problem. They always show you this illustration. But we've seen some examples of them. People who you see diminutive people. I've had a lot of students that have had growth hormone supplement now that they make it genetically over the years, who were under those guidelines. I mean, and unfortunately, when people have these, my favorite giant, Andre the Giant, okay, Princess Bride, Andre the Giant, professional wrestler, Jessica. You have no idea what I'm talking about. You never saw the Princess Bride? You've lived a very sheltered life. I know. Next lab will do clips. That was a movie made by the late Rob Reiner. He directed it, and Mel Brooks, undoubtedly fronted the money. He and his dad, Carl Reiner, undoubtedly fronted the money. Brilliant, right? So this is thyroid stimulating hormone. Again, it's tropic. Stimulates the thyroid keeps you. When we get to thyroid, basically it's a release hormone, rising levels inhibited. That's all. Also growth hormone inhibiting hormone, because they kind of work in concert. Again, thyroid's sort of like your body's metabolic engine. When we're hyperthyroid, we'll go into it, increased activity, perspiration, typically rapid heart rates, typically food goes through you very quickly, rather than hypothyroid, where people are dry, very inactive, and it's different when it affects them in youth versus adults. It's very interesting thyroid problems that are there. So again, this is giving you an idea of where it's from the hypothalamus, which 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 thyroid hormones feed back. When they're sufficient, they feed back either positive, effectively. It's negative feedback when there's an abundance. They stop the secretion of thyroid release hormone, as well as on the anterior pituitary on thyroid stimulating hormone. So you can begin to see the difference between when stimulates, you can see that. Inhibits means those hormones, when they're in abundance, will inhibit both the hypothalamus and the anterior pituitary. ACTH. Anecdote. My dad, and who knew why, but we had ACTH that somehow, it wasn't made genetically at the time, this is way back. He'd go to his doctor, he'd say, I feel much better. I was feeling kind of, I got a shot of ACTH. They used to use it. For whatever reason, was not clear. I don't know that the doctor, who's the old-time family doctor, the old-time general practitioner, he just kind of he knew magical ways to make you get better that were there. So I don't know why it necessarily helped him, but there was a lot of things that are there. So the cells you don't have to know, but effectively it's a precursor to a variety of different substances that are there. It's triggered, okay, and it regulates. It's triggered by corticotropin releasing hormone, and it's part of a daily rhythm. Most of us, the morning, it's based on what kind of, if you're working, and depending on the kind of field you're going to be in. If you're in a clinical field, a lot of people like to work late. So my morning is a typical morning. My wife's morning, she works 3 to 11 most of her life, is a little bit later. She stays up very late. It's just the nature of the beast. So But whatever your morning is when we see the highest level. And that plays an interesting role when we start talking about steroids, when we actually look at the glands themselves. So a lot of different factors are there. Typically, what causes you, this plays a major role in you responding to stressors. Fever, low blood sugar, stress in general. They tend to trigger outpourings of these. Okay, and what they tend to do is, we'll see when we get to the gland itself, tends to elevate your blood pressure, provide the energy kind of boost, means it tends to provide glucose. Even though it is not a major burst, it does provide certain kinds of testosterone-like substances from the adrenal cortex. When we look at the adrenal cortex, you'll see all of that. So it was like a general pick-me-up. People felt better. Perhaps people felt more virile. I don't know. I don't know. As a kid, I never asked my dad. I think it was just something the doctor gave me. And so, and these are the ones that you'll become undoubtedly the most. Three of them are all about reproductive. So it's easy to remember. You have HGH, growth hormone affects all the cells. Thyroid stimulate. It's going to be affecting the thyroid, but the thyroid indirectly targets all the cells. The adrenal cortical tropic hormone, or ACTH, the adrenal cortex, and everything else is reproductively oriented. So FSH and LH, gonadotrophic cells, the big player you're going to learn about down the road when we do this mostly in ReproPhys is GnRH, gonadotropin releasing hormone. It triggers these to be produced. So FSH stimulates gametes, LH gonadal hormones, and additionally maturation that follows. You'll get to when triggers ovulation. Okay, in males, production of testosterone, big players. They're absent in the blood in the prepubescent boys and girls. That's an interesting thing we talk about when we get into repro. What kind of magically makes this occur? It's an odd cycle. We see a little bit more positive feedback, particularly in the female reproductive area, than almost anywhere else. So that's one of those, as well as blood clotting. So GnRH during and after puberty, and effectively the feedback again is negative feedback when you have a sufficient amount of estrogen, progesterone in your bloodstream. And then a prolactin, not clear, not well understood in males, fairly clear in females, but it's controlled by prolactin inhibiting hormone, which is dopamine, interestingly enough. Prevents the release until needed with decreased levels leading to lactation. So one would surmise that dopamine levels drop, and then there's no inhibitory force, it produces normally. Again, it's not clear the role there. We do know it plays a role in lactation. Okay, and I don't know. I mean, it's. My wife nursed all of her five, and I know that my daughter and my granddaughter were tried but were unable to. So I mean, I know that's. I do not know enough about that. Our nursing department will have experts on all. So prolactin, increased estrogen levels, stimulated, reason behind breast tenderness during the menstrual cycle, etc., swelling, rise toward the end of pregnancy, and then suckling stimulates it, release, and promotes the continued milk production. I mean, these are generally accepted types of things that are there. So hypersecretion, much more common, not a problem except in anyone except hypo, unless women who choose to nurse, maybe that's the case. Hyper is the most frequent abnormality with the anterior pituitary tumors that are there. And notice what they are. They play a reproductive role as well because of not just the lactation, but menstrual period interruptions, infertility, and impotence. I mean, those are the kinds of things we often look for those in the reproductive area, but probably have to do a more thorough workup. It's when we get there with repro, I'll frame it because I do know a lot about the infertility. That was the workup that my first wife, when we were trying to have kids, biologically. So I have my context that I told you before is not what happens when it works right. Sort of, I understand what it works right by understanding what happens when it doesn't work right. And then they shows you some nice pictures, very attractive. And we're done with that. Happy dance. And in the time remaining, we will start the next one. So we won't get to diabetes today, nor did I anticipate we will, but we'll get to quite a few of these other guys here. So we're starting off with the thyroid. See, here it should have said thyroid somewhere, but butterfly-shaped gland, you can feel. Go to your Adam's apple, and surrounding it on either side, that fleshy area is thyroid. So it's got mounds on either side that are soft, and an isthmus, basically a section that goes across, are the areas, and you'll see that in the illustration. A median mass consistent to connecting rather two lobes. Okay, and it has mostly follicular cells, and they produce this glycoprotein, which is on the way to becoming thyroid hormone, and we call it thyroglobulin. This is a very well understood pathway that you do need to be very familiar with. What fills the glandular, again, the glands are typically, remember the way I drew them in anatomy, you basically have a series of, here's a typical glandular pocket. Looks like that. You have a mound of cuboidal cells, not scale or anything like that, and they're producing this material, and it inevitably stains a reddish color, so this is useful. The middle, called thyroglobulin. As long as we have iodine, we can make thyroid hormone. The absence of iodine, it just accumulates there, and the gland gets bigger and bigger and bigger. Irregularities in thyroid, nodules in thyroid, things that are tumor or cancer or cancer suggestive are very common. In the interest of not violating HIPAA, but she's my sister. My sister in January had the rest of her thyroid removed because there was a nodule in there. They biopsied. It wasn't cancerous, but the doctor's like, it's growing a little fast. Time. She's been on thyroid supplements for a long time. She's very tiny. Remember I told you she weighs what she did in college? I weigh less than I did in college. 280. You, me, and 6 other guys could have gotten into my pants. I had like size 52s. But and you think this is funny? My friends used to give me a rope, tie it around your waist, Lou. We're gonna have a float to parade. Now use the term friends advisedly. So the colloid fills that and will become that. They are made by the typical follicular cells. There are additional cells that make calcitonin. You remember that from bone. We talked about that with bone. That calcitonin is sort of an oddball. It puts calcium into bone, takes it out of the bloodstream. And again, in an adult, it really doesn't have a whole lot of, so losing a thyroid in an adult or removing it. Very good illustration. And the big deal, anatomically, it has an immense blood supply, as most endocrine glands do. Because it's almost like it's oozing out of them in the blood, and the blood supply around it, all the blood vessels, the capillary net, swallow it up. And the first thing, I think I told you this, we would do a thyroid extraction, which are done all the time. This is probably the same way they did it. I mean, basically, you're taking out a thyroid, and there were like 50 or 60 clamps, tiny hemostats. The surgeons then did mostly hand ties rather than because he was old school. I mean, he was super fast. He'd pop out an appendix in 5 minutes, skin to skin. That's from making the cut to finishing the sutures. Man, it's remarkable. Nevertheless, this tremendous amount of bleeding, had to be very careful with the extraction because you can remove the thyroid, but the parathyroid, if you remove it, it is fatal. We need the parathyroid. We don't need the thyroid. People have been using thyroid supplement for a long, long time. So it has a very large blood supply, and you can see the proximity to a lot of other blood supply. Here's that superior thyroid artery coming off what appears, this would describe as being the internal, but let's say for the argument's sake, common carotid for the time. And here we are. And here are the colloid, much better than I drew it. Here you can see the cuboidal cells, typically round nuclei. And in this area here, this is where you will find the parafollicular cells, okay, that are there. And there'll be tiny blood vessels within there as well. So the major metabolic hormone controlling your metabolic rate. Too much, too fast, not enough, not fast enough. So we hear hyperthyroid, too much, hypo, not enough, EU thyroid, normal. So they are both T4 and T3. T3 is the more, I'm trying to think of the way to describe it, common of these, but when it gets to the tissue levels, if we convert it to T4, you'll see, okay, the iodine amine. So we're going to see two tyrosines, anti-parallel, and one of them has either, we have basically tack on 4 iodines or only 3 iodines. And we always call them T3 and T4. So when you do a thyroid workup, you're looking at TSH levels, thyroid stimulator, all what you're measuring that are there, TSH levels, T3 levels, T4 levels. You look for all of those kinds of levels. And there's a thyroid binding globulin. That's the way because the way it's, remember, it's fatty by nature. It's made of amino acids, but the symmetry and the small molecule makes it effectively nonpolar covalent. So it will not dissolve in the plasma. So it has to have a carrier molecule. That's that thyroid binding globulin. And you measure all of those levels to basically in an endocrine workup or thyroid workup to see what's what. Every cell in the body. When you look at what it does, you can imagine if thyroid is off, how you are in trouble. Enters a target cell, intracellular receptors, transcription, translation, we've seen that movie. Increases basic metabolic rate and heat production, calorogenic effects. Just generating calories as units of heat. Tissue growth and development, critical for skeletal and nervous system development and reproduction. Blood pressure, adrenergic receptors, we already talked about. These are ones in the blood vessel. And you'll see they have a nice chart showing how it interacts with all organs. Stores hormone extracellularly in the follicle lumen. The lumen is the space. That's why I mean extracellularly, until triggered to release it by TSH. But there could be problems. So it's synthesized and discharged into the lumen. Iodide ions are actively taken in, and it goes through the conversion process and all this nonsense. I'm not doing the balancing the chemical equations. It's all about the tyrosine. And so effectively, and they put them in vesicles combined with a lysosome, and they cleave it and you can go through all this elaborate steps until it's exocytosed. The big thing to look at is it has to have the iodide, the I with the negative sign, available. Okay? It has to have that in order to be able to do so. Understand what's coming in. You begin to see these different things that are there. Iodide is trapped, actively transported in. Okay. Iodide is oxidized into iodine, and you see what happens inside the cell. Right? So we make the double units and the mono units, and we combine them. So the iodated, once the iodine is there, then it combines within the colloid. This all occurs in the colloid. Then the iodated tyrosines, because that's what they were tyrosines. They're part of the molecule. They have to be brought in. They're basically they're generated rather through the smooth and rough endoplasmic reticulum, Golgi, and secreted into the lumen. So voila, here we are. Thyroglobulin colloid is endocytosed, combined within a lysosome, and then it's cleaved in such a way that we either get T3 and T4. I'm not going to go over the steps, but the important factor here is we have to have tyrosine synthesized. We have to have iodine available. And then all this happens hunky-dory. Everything works out great. So then it's transported in the bloodstream by these binding globulins to all of its receptors. T3 is 10 times more active. Peripheral tissues have an enzyme needed to convert T4 to T3. So that was a misprint before, and I thought so looking for it. The more active form is T3, not T4, and they had it fast backwards in that previous slide. So, thyroid stimulating hormone, there's thyroid hormone, negative feedback. It can be inhibited by GHIH, we looked at that before, dopamine, and increased levels of cortisol and iodine. All of those can have an inhibitory effect. And so the thyrotropin releasing hormone from the hypothalamus can overcome negative feedback during certain things. Pregnancy, exposure to cold, particularly in infants. So it's a way of generating heat that will overcome the mechanism. So it's a very elaborate hormone. They're showing you the arc again. The stimulating, very similar to what we saw before. And then you can see the feedback mechanisms that are there. This gives you an idea, without having to blow it up, its effect. Basal metabolic, carbohydrate and lipid protein metabolism, nervous system, cardiovascular, muscular, skeletal, GI, repro, integument. All of these are regulated into some degree by thyroid. So it's critical. And particularly when you talk about nervous system development, there are a lot of well-known hereditary and acquired in infancy or pre-birth, which lead to some pretty significant, not really good things to happen to babies who are born with that. They become, long-term care problems that are there. So, for instance, in adults, something called mixed edema, low metabolic rate, the skin is not overly, because you don't secrete a lot, eyes are puffy from a lot of fluid, you don't generate that rapidly generate the sort of shivering of the muscles, your GI tract doesn't work. Edema is because we don't move fluid around fast enough, and in that case, the gravity will basically take it into the lower extremities. Mental sluggishness, lethargy, that's a really significant problem. Whenever we see edema, the most common reason why people get fluid in their legs, particularly, is typically cardiac or kidney. If it's obstructive, it'll be on one side. If it's cardiac or kidney, it's typically on both sides. When we see that, it's like, okay, the difference here is that if you don't see, basically it's a process of elimination. Well, their heart and kidneys are working fast. There's no obstruction anyplace. What's going on here? And then you start looking deeper. And then inevitably you'll do a thyroid panel. You do a lot of thyroid panels. Ooh, why don't you remind me? In lab on somebody send me an email, remind me. I reset my password, now I forgot. It's terrible. Such a dope. Resetting my password because I can see my UPMC. Okay, and so this is the classic one. It's called goiter. Goiter is we don't see it now. Okay, it means it's typically almost always due to insufficient iodine in the diet. So we took care of that. Most of you should know about this. It's iodized salt. Any salt that you commercially, if you go out and buy sea salt or Himalayan pink salt, like we do, okay, that does not have iodine. That if it has iodine, it's a tiny amount. You only need a tiny amount. Most of the time, you go to the store, it'll say iodized salt. Salt shaker, iodized salt. If you see foods that are packed that says salt for packaging in commercial foods, iodized salt. We get plenty of iodine from our diet. You don't have to really worry about it, certainly not around here. But without that, what happens is it's a vicious cycle. You can't produce T3 and T4. Your body senses it by way of that arc in basically the hypothalamus says, wait a minute, low on T3 and T4, you generate the thyroid to get busier, it stores more globulin, but the globulin without the iodine is just going to get larger and larger. Hence the enlargement of fluid being trapped. So it's really significant. Congenital hypothyroidism is typically associated, okay, with poor development of the glands. Meds can play a role in it. A lot of different things are part of it. And these folks, they really have to be identified early on, or this will create significant problems. Sometimes, because of the nervous system development, it can lead to mental issues, mental disabilities. That R word we don't use anymore. That's a goiter. So that's fluid enlargement. With iodine, that will resolve in itself. Not a problem. So it's not there. So hypersecretion is actually an autoimmune phenomenon. Interesting. It's got a great name called Graves' disease. And typically we'll see there's so much fluid collection, typically behind the eyes, it's almost like they pop out. You will see people with this. People you weren't, it's more common than you think. It's called exophthalmic goiter. I never forget the name because my wife's last name is Graves. So autoimmune disease makes abnormal antibodies against the follicular cells. The antibodies act like TSH, stimulating thyroid release, all of these things, elevated heart rate, sweating, etc., etc. We think it's just, there just seems to be as an odd thing with it, this exophthalmic goiter. Okay, and so you have to do something. And for years they used radioactive iodine. That's really what it looks like. The eyes protrude very, very distinctly. So that's one of those things we call a tell, a giveaway. Clinicians look for this all the time. It looks like it is, and it's really significant. When you see things, if you see, remember I talked about osteogenesis imperfecta, where there's a defect in the bone forming of the matrix, and they had a blue sclera. Okay, so it's a collagen-based problem, and in the light, it basically appeared bluish in color. The parafollicular cells, okay, they are the ones. Remember, they work opposite. They put calcium in bone, so they antagonize. Again, we don't know really a whole lot. We think it's much more active in children. Okay, in adults, we're not sure of it. Does it inhibit osteoclastic activity? It's not, it doesn't allow bone to break down. Calcium uptake is part of it. They're again in that area. And we'll stop it here. We're going to do parathyroid, adrenal, and at least start diabetes and probably finish it on Monday, I would think. Thank you very much. Have you, if you want to look at tests, I'm not going to be in today. After this, I have to hit home, but I will be in my usual 12 to 2 on Friday.